Degenerative neurologic disorders, multiple sclerosis. MS is a chronic progressive degenerative disorder of the CNS characterized by disseminated demyelination of nerve fibers of the brain and spinal cord. MS can affect people of any age. The onset of MS is usually between 20 and 50 years of age, with symptoms first appearing at an average of 30 to 35 years of age. People diagnosed at 50 years of age or older generally have more progressive disease. MS affects women 2 to 3 times more often than men. Around 400,000 people in the United States have MS, 10,000 new cases diagnosed annually. MS is more prevalent in temperate climates between 45 and 65 degrees of latitude, such as those found in the northern United States, Canada, and Europe. People who are born in a high-risk area and move to a lower-risk area before age 15 assume the risk of their new home. We suspect exposure to some environmental agent before puberty may cause a person to develop MS later in life. MS is less common in Hispanics, Asians, and people of African descent. It rarely occurs in some ethnic groups, including Alaskan Natives and Aborigines. Etiology and pathophysiology. While we do not know the cause of MS, it is unlikely due to a single cause. We think MS develops in a genetically susceptible person after an environmental exposure, such as an infection. The inherited susceptibility to MS likely involves multiple genes. Having a first-degree relative with MS increases the person's risk for developing the disease. We've found common genetic factors in families with more than one affected member. Possible precipitating factors include infection, smoking, physical injury, emotional stress, excessive fatigue, pregnancy, and a poor state of health. The role of factors such as exposure to pathogens is controversial. We have investigated more than a dozen viruses and bacteria but have not proven any cause MS. MS is marked by three processes: chronic inflammation, demyelination, and gliosis in the CNS. Primary condition is an autoimmune process driven by activated T cells. An unknown trigger in a genetically susceptible person may start this process. The activated T cells in the systemic circulation go to the CNS and disrupt the blood-brain barrier. This may be the first event in the development of MS. Subsequent antigen-antibody reaction within the CNS activates the inflammatory response and leads to axon demyelination. Attacks on the myelin sheaths of the neurons in the brain and spinal cord first cause damage to the myelin sheath. The nerve fiber is not affected. Transmission of nerve impulses still occurs, but it is slowed. The patient may have a noticeable impairment of function, e.g. weakness. However, myelin can still regenerate. When it does, symptoms disappear. At this point, the patient has a remission. If inflammation continues, nearby oligodendrocytes are affected. Myelin loses the ability to regenerate. Eventually, damage occurs to the underlying axon. Nerve impulse transmission is disrupted and nerve function is lost permanently. As inflammation subsides, glial scar tissue replaces damaged tissue. This leads to the formation of hard, rigid plaques. These plaques are found throughout the white matter of the CNS. The average life expectancy after the onset of symptoms is more than 25 years. Death usually occurs due to infections, complications of immobility, e.g. pneumonia, because of an unrelated disease. Clinical manifestations. The onset of MS is often slow and gradual. Vague symptoms occur periodically over months or years. Because they do not prompt the patient to seek medical attention, MS may not be diagnosed until long after the first symptom. For some patients, MS is marked by rapid progressive deterioration. Others have remissions and exacerbations. With repeated exacerbations, the overall trend is progressive deterioration in neurologic function. Because changes from MS have a spotty distribution in the CNS, Symptoms vary with each patient based on the areas of the CNS involved. Some patients have severe, long-lasting symptoms early in the course of the disease. Others have only occasional mild symptoms for several years after onset. Classification scheme of MS with 4 primary patterns has been developed based on the clinical course. The first symptom of MS may be blurred or double vision, red-green color distortion, or even blindness in one eye. Many patients describe extremity muscle weakness and problems with coordination and balance. Those symptoms may affect walking or standing. MS can cause partial or complete paralysis in the worst cases. Most have numbness and tingling. Lhermitte's sign is a temporary sensory symptom described as an electric shock going down the spine or into the limbs with neck flexion. Some patients report pain, especially in the low thoracic and abdominal regions. Other frequent problems include speech impairment, hearing loss, tremors, and dizziness. Possible cerebellar signs include nystagmus, ataxia, dysarthria, and dysphagia. Most patients have severe, even disabling fatigue. This is worsened by heat, humidity, deconditioning, and medication side effects. A rigid plaque is in areas of the CNS that control elimination, and bowel and bladder function. Yeah, it's a horrible typo of some kind. Bowel problems usually involve constipation. Urinary problems vary. Common problem in patients with MS is a spastic, uninhibited bladder. Bladder has a small capacity for urine, and its contractions are unchecked. The result is urinary urgency and frequency, often with dribbling or incontinence. A flaccid hypotonic bladder occurs with a lesion in the reflex arc controlling bladder function. The patient generally has urinary retention because there is no sensation or desire to void, no pressure, no pain. Urgency and frequency may be present. A combination of spastic and flaccid bladder can occur. Urinary problems can be diagnosed with urodynamic studies. Sexual problems occur in many people with MS. Physiologic erectile dysfunction may result from spinal cord involvement in men. Women may have decreased desire for sexual activity, libido, difficulty with orgasm, painful intercourse, and decreased vaginal lubrication. Decreased sensation can prevent a normal sexual response in men and women. Emotional effects of chronic illness and the loss of self-esteem contribute to loss of sexual response. Some women with MS have remission or an improvement in their symptoms during pregnancy. Hormonal changes associated with pregnancy appear to affect the immune system. About half of people with MS have problems with cognitive function. Most involve problems with short-term memory, attention, information processing, planning, visual perception, and word finding. General intellect stays unchanged and intact. This includes long-term memory, conversational skills, and reading comprehension. Symptoms can be mild and thus easily overlooked. However, about 5 to 10% of patients with MS have such severe cognitive changes that they significantly impair the person's ability to perform activities of daily living. Most of the time, cognitive difficulties occur later in the course of the disease. However, they can occur early and sometimes are present at the onset. People with MS have emotional changes such as anger, depression, or euphoria. Physical and emotional trauma, fatigue, and infection may worsen or trigger signs and symptoms. Diagnostic studies. Because there's no definitive diagnostic test for MS, the history, manifestations, and results, certain diagnostic tests are important. Imaging in MS is vital. An MRI of the brain and spinal cord may show plaques, inflammation, atrophy, and tissue breakdown and destruction. CSF analysis may show an increase in IgG in the presence of oligoclonal banding. Evoked potential responses are often delayed because of decreased nerve conduction from the eye and ear to the brain. To be diagnosed with MS, the patient must have 1. Evidence of at least 2 inflammatory demyelinating lesions in at least 2 different locations within the CNS, 2. Damage or an attack occurring at different times, usually 1 month or more apart, and 3. All other possible diagnoses ruled out. If evidence exists for only 1 lesion or only 1 clinical attack has occurred, the HCP will monitor the patient for another attack or for an attack at a different site in the CNS. Interprofessional care, drug therapy. Because no cure currently exists for MS, interprofessional care is aimed at treating the disease process and providing symptomatic relief. No cases of MS are alike, so we tailor therapy to the disease pattern and symptoms of each patient. Disease-modifying therapy has been found to be more effective started early in the course of MS. Delays in treatment are linked to poor outcomes. Treatment of MS begins with use of immunomodulator drugs to modify disease progression and prevent relapses. These drugs include 1. Interferon beta-1a, Rebif, Plegridy, Avonex. 2. Interferon beta-1b, Betaseron, Extavia. And 3. Glatiramer acetate, Copaxone, Glatopa. Teriflunomide Aubagio is an immunomodulatory agent with anti-inflammatory properties. The exact mechanism of action is unknown. It may reduce the number of activated lymphocytes in the CNS. Fingolimod, Gilenya, and Siponimod Mayzent reduce MS disease activity by preventing lymphocytes from reaching the CNS and causing damage. These drugs are used to treat relapsing forms of MS. For more active and aggressive forms of MS, natalizumab, Tisabri, alemtuzumab, Lemtrada, Metoxantrone, ocrelizumab, Ocrevus, and dimethylfumarate, Tecfidera, may be used. Natalizumab is given when patients have had an inadequate response to other drugs. An adverse effect of natalizumab is the increased risk for a potentially fatal viral infection of the brain, progressive multifocal leukoencephalopathy. Because of its safety profile, alemtuzumab is reserved for patients who have an inadequate response to 2 or more drugs used for the treatment of MS. Mitoxantrone is an anti-neoplastic medication with serious effects. It includes cardiotoxicity, leukemia, and infertility. Use of ocrelizumab increases the risk for breast cancer. Dimethylfumarate treats MS by activating the NRF2 pathway. This pathway provides a way for cells in the body to defend themselves against the inflammation and oxidative stress caused by MS. Corticosteroids, e.g. prednisone, are most helpful to treat acute exacerbations of MS. They reduce edema and acute inflammation at the site of demyelination. However, they do not affect the ultimate outcome of the degree of residual neurologic impairment for disease exacerbation. Therapeutic plasma exchange, plasmapheresis, and IVIGG may be considered for a short time when treatment with corticosteroids alone does not achieve symptom improvement. Many other drugs are used to treat the various symptoms of MS. These may include drugs for spasticity, fatigue, tremor, vertigo or dizziness, depression, pain, bowel and bladder problems, sexual problems, and cognitive changes. For example, amantadine, modafinil, Provigil, and fluoxetine Prozac are used to treat fatigue. Anticholinergics can treat bladder symptoms. Tricyclic antidepressants and anti-seizure drugs are used for chronic pain syndromes. Dalfampridine, Ampyra, may improve walking speed in MS patients. It is a selective potassium channel blocker that improves nerve conduction in damaged nerve segments. It should not be used in patients with a history of seizure disorders or with moderate to severe kidney disease. Other therapies. Spasticity is treated mainly with muscle relaxants. Other options include surgery, e.g. neurectomy, rhizotomy, chordotomy, dorsal column electrical stimulation, or intrathecal baclofen, lioresal. Tremors have become unmanageable with drugs or sometimes treated by thalamotomy, or deep brain stimulation. Neurologic dysfunction sometimes improves with physical and speech therapy. Exercise improves daily functioning for patients not having an exacerbation. Exercise decreases spasticity, increases coordination, and retains unaffected muscles to act for impaired ones. Retrains. An especially beneficial type of physical therapy is water exercise. Water, which gives buoyancy to the body, allows a patient to have more control over the body and perform activities that would otherwise be impossible. Nursing management, nursing diagnoses, impaired physical mobility, difficulty coping, urinary retention. Planning. Overall goals: 1. Maximize neuromuscular function. 2. Maintain independence in ADLs for as long as possible. 3. Manage fatigue. 4. Optimize psychosocial well-being. 5. Adjust to the illness. 6. Reduce factors that precipitate exacerbations. Nursing implementation. The patient with MS should be aware of triggers that may cause worsening of the disease. These include infection, especially upper respiratory and urinary tract, trauma, immunization, childbirth, stress, and change in climate. Each person responds differently to triggers. Help the patient identify triggers. Develop ways to avoid them or decrease their effects. During the diagnostic phase, reassure the patient that certain diagnostic studies must be done to rule out other neurologic disorders, even if a tentative diagnosis of MS has been made. Help the patient deal with anxiety caused by a diagnosis of disabling illness. A patient with recently diagnosed MS may need help with the grieving process. During an acute exacerbation, the patient may be immobile and confined to bed. The focus of nursing interventions at this phase is to prevent complications of immobility. These include respiratory and UTIs and pressure injuries. Focus patient teaching on general resistance to illness. This includes avoiding fatigue, extremes of heat and cold, exposure to infection. Encourage early treatment of infection when it occurs. Teach the patient to seek a good balance of exercise and rest, minimize caffeine intake, and eat nutritious, well-balanced meals. Patients should know the treatment plan, direct side effects, how to identify and manage side effects, drug interactions with OTC drugs. Patients should consult the HCP before taking any OTC drugs. Bladder control is a major problem for many patients with MS. Anticholinergics may help some patients to decrease spasticity. You may need to teach others self-catheterization. Constipation is common. Diet high in fiber may help relieve constipation. Patients with MS and caregivers need to make many emotional adjustments because of disease unpredictability, the need for lifestyle changes, and the challenge of avoiding or decreasing precipitating factors. The uncertainty of disease progression, along with fatigue and decreased mobility, may cause anxiety and depression. The National MS Society, its local chapters, offer a variety of services to meet the needs of patients with MS. Evaluation, the expected outcomes: maintain or improve muscle strength and mobility, use assistive devices appropriately for ambulation and mobility, maintain urinary continence, make decisions about health and lifestyle modifications to manage MS. Parkinson's disease. Parkinson's disease is a chronic progressive neurodegenerative disorder characterized by slowness in the initiation and execution of movement, bradykinesia, increased muscle tone, rigidity, tremor at rest, and gait changes. It is the most common form of Parkinsonism syndrome characterized by similar symptoms. Up to 1 million Americans will be living with PD by 2020. 60,000 persons are diagnosed each year. Incidence of PD increases with age. Though 4% of people with PD are diagnosed before age 50 years, men are 1.5 more times likely to have PD than women. Etiology and pathophysiology. The exact cause of PD is unknown. Although we do not consider PD a hereditary condition, genetic risk factors should be evaluated for their interplay with environmental factors. Exposure to well water, pesticides, herbicides, industrial chemicals, and wood pulp mills may increase risk for PD. Rural residence is considered a risk factor. Many forms of secondary atypical Parkinsonism exist other than PD. Symptoms of Parkinsonism have occurred after exposure to a variety of chemicals, including carbon monoxide and manganese, among copper miners. Drug-induced Parkinsonism can follow therapy with metoclopramide, Reglan, reserpine, methyl-dopa, lithium, haloperidol, Haldol, and chlorpromazine. It can be seen after the use of illicit drugs, including amphetamine and methamphetamine. After stopping these drugs, symptoms of Parkinsonism generally disappear. One notable exception is irreversible Parkinsonism that follows exposure to the product of meperidine analog synthesis, MTPT. Other causes include hydrocephalus, other neurodegenerative disorders, hypoparathyroidism, infection, stroke, tumor, and trauma. Many changes found in the brains of people with PD may play a part in the development of the disease, including a lack of DA. The pathologic process of PD involves degeneration of the DA-producing neurons in the substantia nigra, the midbrain. This in turn disrupts the normal balance between DA and acetylcholine in the basal ganglia. The neurotransmitter DA is essential for normal functioning of the extrapyramidal motor system. including control of posture, support, and involuntary motion. Voluntary. Manifestations of PD do not occur until 80% of neurons in the substantia nigra are lost. Unusual clumps of protein called Lewy bodies are found in the brain. Patients with PD, it is not known what causes Lewy bodies to form. Their presence indicates abnormal brain functioning. Lewy body dementia is discussed in Chapter 59. Genetic link. We do not fully understand how genetic changes cause PD or influence the risk for developing PD. Around 15% of patients with PD have a family history of PD. Many autosomal dominant and recessive genes are linked to familial PD. Autosomal dominant PD is rare, affecting only 1 or 2% of people with PD. Examples include the SNCA and LRRK2 genes. Mutations in the LRRK2 gene also appear to have a role in non-inherited sporadic cases of PD. Recessive genes include PARK1, PARK2, PARK7, and PINK1. Mutations in these genes are often associated with a younger age of disease onset. They also have more manifestations compared to those typically seen with age-related PD. PINK1 mutations are related to a rare early onset form of PD. Clinical manifestations. The onset of PD is gradual with an ongoing progression. Only one side of the body may be involved at first. Classic manifestations can be remembered by the mnemonic TRAP: tremor, rigidity, akinesia, postural instability. Early in the disease, only a mild tremor, slight limp, or decreased arm swing may be seen. Later, the patient may have a shuffling gait and appear unable to stop. The patient's arms are flexed and postural reflexes seem to be lost. The patient may have speech problems. Hypokinetic dysarthria can affect communication and quality of life. Tremor. Tremor is often the first sign, may be minimal at first, so the patient is the only one who notices it. This tremor can affect handwriting, causing it to trail off, especially towards the end of words. Parkinsonian tremor is more prominent at rest. It is worsened by emotional stress or increased concentration. The hand tremor is described as pill rolling because the thumb and forefinger appear to move in a rotary fashion as if rolling a pill, coin, or other small object. Tremor can involve the diaphragm, tongue, lips, and jaw. Rarely causes shaking of the head. Unfortunately, many people with benign essential tremor is mistakenly diagnosed as PD. Essential tremor occurs during voluntary movement, has a more rapid frequency than Parkinsonian tremor, and is often familial. Rigidity. Rigidity is the increased resistance to passive motion when the limbs are moved through the range of motion. ROM. Parkinsonian rigidity is typified by a jerky quality cogwheel rigidity, as if there were occasional catches in the passive movement of a joint. Sustained muscle contraction causes the rigidity and results in muscle soreness, feeling tired and achy. Pain in the head, upper body, spine, or legs. Slow movement is another result of rigidity because the alternating contraction, relaxation, and opposing muscle groups, e.g. biceps and triceps, is inhibited. Akinesia. Akinesia is the absence or loss of control of voluntary muscle movements. In PD, bradykinesia, slowness of movement, is especially evident in the loss of automatic movements. This occurs because of the physical and chemical change of the basal ganglia and other structures in the extrapyramidal portion of the CNS. In the unaffected patient, automatic movements are involuntary and occur subconsciously. They include blinking of the eyelids, swinging of the arms while walking, swallowing saliva, using facial and hand movements for self-expression, and making minor movements to adjust posture. A patient with PD does not perform these movements and lacks natural activity. This accounts for the stooped posture, masked face, deadpan expression, drooling, saliva, and shuffling gait, festination, typical of a person with PD. Posture is that of a slowed old man image with the head and trunk bent forward and the legs constantly flexed. Postural instability. Postural instability is common. Patients may describe being unable to stop themselves from going forward, propulsion, or backward, retropulsion. Assessment of postural instability includes the pull test. Examiner stands behind the patient and gives a tug backward on the shoulder, causing the patient to lose their back balance and fall backward. Many non-motor symptoms are common. They include depression, anxiety, apathy, fatigue, pain, urinary retention, constipation, erectile dysfunction, and memory changes. Sleep problems are common. They include difficulty staying asleep at night, restless sleep, nightmares, and drowsiness, or sudden sleep onset during the day. Rapid eye movement, sleep behavior disorder is a pre-Parkinsonian state that occurs in about 1/3 of patients with PD. It's characterized by violent dreams and potentially dangerous motor activity during REM sleep. It may cause harm to the patient or bed partner. Complications. As PD progresses, complications increase. These include motor symptoms, e.g. dyskinesias, spontaneous involuntary movements, weakness, neurologic problems, e.g. dementia, and neuropsychiatric problems, e.g. depression, hallucination, psychosis. As PD progresses, dementia often results associated with increased mortality. As swallowing becomes more difficult, dysphagia, malnutrition, or aspiration may result. Increasing weakness may lead to pneumonia, UTIs, and skin breakdown. Orthostatic hypotension is common. Along with loss of postural reflexes, it can cause falls or other injury. Patients' increased fall risk means caregivers must be aware of environmental conditions that can contribute to falls. Diagnostic studies. Because no specific diagnostic test exists for PD, diagnosis based on the patient's history and clinical features. Clinical diagnosis requires the presence of TRAP and asymmetric onset. What's TRAP again? Tremor, rigidity, akinesia, postural instability. Okay. Confirmation of PD is a positive response to anti-Parkinsonian drugs, levodopa or DA agonist. MRI and CT have a limited role in diagnosis of PD because they do not show specific pathologic finding. However, they can rule out a stroke or brain tumor. Interprofessional care. Because PD has no cure, interprofessional care focuses on symptom management. Drug therapy. Drug therapy for PD is aimed at correcting the imbalance of neurotransmitters within the CNS. Anti-Parkinsonian drugs either enhance the release or supply of DA, dopaminergic, or block the effects of the overactive cholinergic neurons in the striatum. Anticholinergic. Levodopa with carbidopa, Sinemet is a primary treatment for symptomatic patients. Levodopa is a chemical precursor of DA and can cross the blood-brain barrier. It is converted to DA in the basal ganglia. Sinemet is the preferred drug because it also contains carbidopa, an agent that inhibits the enzyme dopa decarboxylase in the peripheral tissues. Dopa decarboxylase breaks down levodopa before it reaches the brain. The net result of using this combination is that more levodopa reaches the brain, thus less drug is needed. Levodopa has many side effects and drug interactions. Prolonged use often results in dyskinesias and on-off periods when the medication will unpredictably stop or start working. Many patients receive Sinemet early in the disease course for the management of motor symptoms. However, some HCPs think that after a few years of therapy, the effectiveness of Sinemet wears off. Therefore, they prefer to start therapy with a DA receptor agonist, drug that directly stimulates DA receptors, ropinirole, Requip, and pramipexole, Mirapex, may be used alone or in combination with Sinemet. Many of these medications are available in extended release forms that improve patients' ability to adhere to treatment plans. Rotigotine, Nupro, another DA receptor agonist, is available as a transdermal patch applied once daily. It is an adjunctive therapy for patients taking Sinemet. The antiviral agent amantadine is a weak antagonist of NMDA-type glutamate receptors. It increases DA release and blocks DA reuptake. It may be useful as a single therapy for early PD. It can be used later with levodopa. As a single treatment, amantadine often becomes less effective after a few months. Withdrawal of amantadine, even after extended therapy, can worsen dyskinesia. Anticholinergic drugs such as trihexyphenidyl and benzotropine cogentin decrease the activity of ACH, providing balance between cholinergic and dopaminergic actions. Antihistamines, e.g. diphenhydramine, with anticholinergic properties, may be used to manage tremors. Selegiline, aldaparil, razagoline, Azilect, and safinamide Hadagal are monoamine oxidase type B MAOB inhibitors. They may be used in combination with Sinemet. By inhibiting MAOB, the enzyme that degrades DA, these agents increase the levels of DA and prolong the half-life of levodopa. Razagoline can be used alone as therapy in early PD. However, MAOB inhibitors are less effective at treating motor symptoms than DA receptor agonists. Entacapone, Comtan, and tolcapone, Tasmar, block the enzyme catechol O-methyltransferase, COMT, which breaks down levodopa in the peripheral circulation. Thus, they prolong the effect of Sinemet and are used only as adjuncts. They're often used when the patient's response to levodopa is wearing off at the end of the dosing interval. Tolcapone is rarely prescribed because it is associated with fatal hepatotoxicity. Rivastigmine, Exelon, and donazepam Aricept used to treat dementia. Amitriptyline may be used to treat depression. The use of only one drug is preferred because fewer side effects occur and the drug dosage is easier to adjust than when several drugs are used. However, as PD progresses, combination therapy is often needed. Excessive amounts of dopaminergic drugs can worsen rather than relieve symptoms, paradoxical intoxication. Within 3 to 5 years of standard PD treatments, many patients have episodes of hypomobility, inability to rise from chair, speak, or walk, also called off episodes. Off episodes can occur toward the end of a dosing interval, standard medications, so-called end of dosage wearing off, or at unpredictable times, spontaneous on-off. Combination of carbidopa, levodopa, and tacopone, Stalevo, is available for patients with end of dose wearing off. It can be prescribed to make dosing easier, with 1 pill substituting for 3. Stalevo is typically prescribed for patients with advanced PD with intense motor fluctuations. The injectable DA receptor agonist, apomorphine, Apoquin, can improve movement in hypomobility episodes. Apomorphine must be taken with an antiemetic drug because it causes severe nausea and vomiting when taken alone. Cannot be taken with antiemetics in the serotonin 5-HT3 receptor antagonist class, e.g. ondansetron, Zofran. This combination can lead to very low BP and loss of consciousness. Surgical therapy. Surgical procedures to relieve symptoms of PD are usually used in patients who are not responsive to drug therapy or who have developed severe motor complications. Surgical procedures fall into 3 categories: deep brain stimulation, DBS, ablation, destruction, and transplantation. The most common treatment is DBS. This involves placing an electrode in the thalamus, globus pallidus, or subthalamic nucleus, connecting it to a generator placed in the upper chest, similar to a pacemaker. The device is programmed to deliver a specific current to the targeted brain location. DBS is preferred to ablation procedures because it is reversible and programmable. It can be safely done bilaterally. DBS reduces the increased neuronal activity produced by DA depletion. It can improve motor function and reduce dyskinesia and medication use. DBS is most effective when patients are carefully selected and screened. Ablation surgery involves finding, targeting, and destroying an area of the brain affected by PD. The goal is to destroy tissue that produces abnormal chemical or electrical impulses leading to tremors or other symptoms. Typical targets of ablation are the thalamus, thalamotomy, globus pallidus, pallidotomy. Newer treatments such as the gamma knife, focused ultrasound, are non-invasive options. Transplantation of fetal neural tissue into the basal ganglia was designed to provide DA-producing cells in the brains of patients with PD. Research of this therapy was largely abandoned after mixed results over several decades. In the last few years, better transplant techniques have renewed interest in this as a potential option. Nutritional therapy. Diet is of major importance to patients with PD because malnutrition and constipation can result from poor nutrition. Patients who have dysphagia and bradykinesia need appetizing foods that are easy to chew and swallow. The diet should contain adequate fiber and fruit to reduce constipation. Eating 6 small meals a day may be less tiring than eating 3 large meals a day. Plan ample time for eating to avoid frustration. Cut food into bite-sized pieces. Protein ingestion and vitamin B6 can impair the absorption of levodopa. Limiting protein intake to the evening meal can decrease the problem. They may need to consult the HCP about including vitamin B6 and a vitamin, multivitamin, and fortified cereals. Nursing management, Parkinson's disease. Nursing diagnoses, impaired physical mobility, impaired nutritional status, risk for fall-related injury, impaired sleep pattern. Planning. The overall goals are that the patient will 1. Maximize neurologic function, 2. Maintain independent in ADLs for as long as possible, 3. Optimize psychosocial well-being. Implementation. Because PD is a chronic degenerative disorder, with no acute exacerbations. Teaching and nursing care are directed toward maintaining good health, encouraging independence, and avoiding complications such as contractures, falls. Problems due to bradykinesia can be addressed by relatively simple measures. Promoting physical exercise and a well-balanced diet are major nursing concerns. Exercise can limit the effects of decreased mobility, such as muscle atrophy, contractures, and constipation. The American Parkinson Disease Association publishes booklets and fact sheets, helpful exercises that can be used by caregivers and healthcare professionals. A physical therapist can design a personal exercise program to strengthen and stretch specific muscles. Overall muscle tone and specific exercise to strengthen the muscles involved with speaking and swallowing should be included. Although exercise will not stop disease progress, it will enhance the patient's functional ability. An occupational therapist can help the patient with ways to increase self-care measures, including eating and dressing. Work closely with the patient's caregivers to find creative ways to promote independence and self-care. The patient can get out of a chair better by using an upright chair with arms and placing the back legs of the chair on small 2-inch blocks. Encourage environmental changes to improve safety. These include removing rugs and excess furniture to avoid stumbling, using an elevated toilet seat to help the patient get on and off the toilet, and elevating the legs of an ottoman to decrease dependent ankle edema. Clothing can be simplified by using slip-on shoes and Velcro hook and loop fasteners or zippers on clothing instead of buttons. Effective management of sleep problems can greatly improve the quality of life for patients with PD. Some patients find the use of satin nightwear or satin sheets helpful. Information on teaching about sleep hygiene practices is discussed in Chapter 7. In the early stages of PD, many patients have depression and anxiety. Patients need to adjust their lifestyle, including work and home responsibilities. As PD progresses, the impact on the patient's psychological well-being increases. Assist the patient by listening, providing teaching, gently correcting distorted thoughts, and encouraging social interactions. Psychologic therapy and counseling can be helpful. Ensure that patients with PD receive prescribed medications on time to avoid on and off effects. In the early stage of PD, the patient may have subtle changes in cognitive function that can progress to dementia. This causes increased caregiver burden and may lead to long-term care placement. Information on care of the patient with dementia is provided in 59. Family members, e.g. spouse, children, care for most patients with PD. The burden increases as the disease progresses. This often occurs while the caregiver's physical and mental health also decline. Help them find appropriate resources. Evaluation. Expected outcomes are that the patient with PD will maintain optimal muscle function, use assistive devices appropriately for ambulation and mobility, maintain nutritional intake adequate for metabolic needs, have unimpaired swallowing of fluids and solids, use methods of communication that allow interaction with others.